Today I'll discuss a patient case, a woman in her 60s who presented with scapular pain on the left, but also trending towards the intrascapular area. Arm symptoms, skipped the forearm and then presented in the hand and fingers primarily as paresthesia. The tips of the fingers were the most pronounced and the pointer finger was the most pronounced and the most constant. So she didn't report neck pain per se, and there was nothing on the right. The symptoms had been present for a few weeks. She thinks it might have been due to a period where she was doing more cleaning. When I think about that as a possible trigger, I'm thinking about the position of cleaning. Of course, you can also think about the muscles worked with cleaning, but when someone presents with scapular, arm, hand, and finger paresthesia, I'm not thinking muscular. I'm thinking a nerve is irritated, and whether or not we can remove that irritation, so to speak, with specific movements or not is the most important question that we need to answer. She's noted that she's been stiff. Her neck has always felt a little bit stiff, but like I said, neck pain wasn't high or wasn't something she was reporting. She reported getting worse with looking down, worse with sitting, and worse with driving. Nothing else was kind of better, it's just avoiding those movements. And so that's consistent with cleaning. Cleaning typically is a lot of looking down. So she has disturbed sleep. That's a main problem here, and inability to sleep on her side as she likes to. This person presents with quite a host of comorbidities. On my radar were bilateral carpal tunnel surgeries in the past, which could be related to this. And I'm not going to go into all the other ones, but suffice to say that the comorbidities were a consideration for me in terms of how to kind of approach this problem and prognosis. Okay, let's go on to the physical exam. So that's kind of a very quick verbal exam. Left fingers, abduction was 4- out of 5, so lacking strength in finger abduction. All the other muscles tested fine. She had a negative nerve tension test in supine for both upper extremities. There are 8 motions of the neck. I examined all 8. Protrusion, no loss, but produced left scapular pain. Flexion had a slight to nil loss and produced pain during movement, increasing numbness. I believe in her hand. I wrote down just increasing numbness. So pain during movement is excluding the fact that this is pain from a tight tissue because the person could go past it. So pain during movement to me largely implicates joint mechanics, first and foremost, although structural problems could be producing pain during movement, but I differentiate most between pain during movement, or PDM, and end range pain, or ERP. Those are just the abbreviations I use in my notes because they do tell me different possibilities. End range pain, for example, could be due to tight tissue because it's produced at the end of the range. Pain during movement is not going to be tight tissue because by definition, tight tissue means it doesn't go further. So if you're getting pain produced during the movement, but you continue to go further, then it's not the tight tissue. That's one aspect of how I use that kind of presentation to differentiate between those two things, but there are multiple other things I'm also considering. Retraction I put as nil to min loss. Extension was minimal loss with production of scapular pain. Lateral flexion away, so toward the right, minimal loss. Lateral flexion toward the left, moderate loss. So significant loss of motion moving toward the side of symptoms. And then rotation left and right of the neck I put as min to mod loss in both directions. Those lateral movements, however, importantly, did not recreate symptoms. But you'll notice that 3 of the 4 motions in the sagittal plane, so the motion of forward and back in the human body, did produce symptoms. I decided to start testing with repeated movement testing. I thought Robin McKenzie's repeated movement testing would be the most important and helpful test to use for this patient. I did not use other clinical tests, orthopedic special tests, for example, or refer for imaging. I started with the repeated movement testing of retraction, extension, and sitting. So it's retraction of the neck, followed by extension, having her go back as far as possible. It produced her symptoms when she did it, but it didn't stay worse after. So in my terminology, it's produce no worse. So we're hitting the problem, so to speak. We're doing something that produces symptoms, but after we stop that movement, it's not remaining revved up or staying worse. The pain, however, each repetition, we did 4 sets of 10. With repetition, the pain that was produced during the movement moved more centrally toward the neck till by the end of the 4 sets of 10, she was reporting left neck pain when she did the exercise. Fingers improved slightly in strength to about 4+ versus 4-. No effect on the lateral movements. I was expecting to see some positive improvement in lateral movements. I did not. So that was something that I was noting because I would expect or I would want improvements, especially in lacking lateral movements, to improve if this is the fruitful motion, but decrease pain with flexion. So kind of 3 positives, which is pain moving centrally with the repeated movement, finger strength improving minimally, but noticeable, pain with flexion decreasing. So 3 positive things, no effect on lateral movements, which I think is neutral to negative. Not negative in terms of making it worse, but negative in terms of not really supporting the idea that retraction extension was the best movement for this patient. But again, 3 things were supporting it. So I did think it was helpful and fruitful to have this patient do more retraction extension. Like I say all the time, when we do a repeated movement test in the office, there are outliers where you will do 30 or 40 and they will get significant resolution of their problem with just that many repetitions, and then doing it at home over a few days gets them all the way there. There are other cases, especially people who present with more comorbidities, especially people who present with more chronic reporting of symptoms, especially people who are older and have other things going on, maybe not pathological, but just other things going on. Those patients, sometimes you just need to see some positive effect that makes you curious about what the effect of more would be. But I tell patients all the time, 30 is usually not going to fix a problem, but 300 will give us a really good idea if we're onto something or not. That's how my testing using Robin McKenzie's work really is different than if you go to see a clinician, a DPT, an orthopedic MD, a chiro, a DO, whomever, ATC. My work really differs from theirs is because I believe on day one, we cannot conclusively say in the large majority of cases, A, what the diagnosis is, and B, what the treatment is, because we need to do sufficient testing. And even if you go to an MD's office and they send you out for an image, well, then they haven't made their diagnosis on day one because they're waiting for the image and the image results to give them more intel. I'm waiting for the repeated movement testing to give us more intel. I choose this test because I think it's the most helpful and the optimal way to get us the best results for patient outcomes. So retraction extension over a chair about 10 every 2 hours. And I described adding overpressure to the end range, and I didn't want to add it quite yet because, this is a little vulnerable. 3 movements in the sagittal plane produce symptoms. She knows she can produce symptoms if she looks down. I didn't want to add overpressure day one, but I said, if in a few days, if in 3 or 4 days, you felt up to the task, I wanted you to start adding a little bit more overpressure to get that extra centimeter or 2 of range of motion into end range extension of the neck. We did speak a lot about posture. It was apparent that her posture, by her reporting, was in a lot of flexion. It was in a lot of flexion, and I think that was important to point out and to possibly correlate to this injury, or at a minimum, correlate with how to get out of this injury state, how to improve things. So we did talk a lot about posture, and I encouraged a more neutral neck posture when looking at the phone or when reading, etc. She presented a week later. She'd been doing the homework as described 6 or more times per day. She only added the overpressure a few times. So I didn't get the data from retraction extension with overpressure. I'm just getting the data with retraction extension. Mostly seated versus standing, which is fine. She said she was still having to clean a lot. I believe she was expecting family. She was still cleaning a lot. So to me, as we discussed in our visit, that means looking down a lot. She did notice that her sleeping was worse. So the physical exam, mild finger loss of strength, so a little bit better, but still not perfect. And then it's a slightly different physical exam picture in terms of mechanics of the neck. Protrusion, not symptomatic, no loss. Flexion, not symptomatic, no loss. So those are both improvements. Retraction, I put as more loss, so moderate loss of retraction, and it produced her shoulder blade pain. Extension, still a minimal loss and increased upper extremity symptoms. And then lateral flexion to the right, still a min loss. Lateral flexion to the left, still a mod loss. And now it produced left neck. So going toward that side produced left neck now, whereas before it didn't. And rotation was about the same. So min to mod loss and no effect on symptoms. So not a much, much better presentation in terms of 8 movements of the neck, but a better presentation overall in my book. Because retraction, whether it's a min or mod loss, that one can be trickier to observe. So I don't put as much, I don't think of this as like she's really losing retraction range of motion. So I looked at her homework. I asked patients, show me the exercise you were doing. She was doing retraction extension, and it was producing no worse again in the office. It would produce arm symptoms and possibly hands and finger symptoms, but not remain worse. I looked at supine retraction to see if a load being in supine versus seated would be more ideal. That was also producing symptoms, but not remaining worse afterwards. So I abandoned that. I looked at thoracic extension and sitting just to see if there was something a little bit lower that I needed to get the fulcrum of extension of the spine lower into the upper thoracic versus the lower cervical or the CT junction. It had no effect during the movement or after, and no effect on mechanics. So I didn't think it wasn't making her worse. My curiosity if it was more benign and we could get her a little bit less stiff in the thoracic spine, maybe going into retraction extension of the neck would be less provocative. So because thoracic extension was not provocative and retraction extension still was, I decided to incorporate thoracic extension to have a pain-free movement that got movement through the system and would possibly help us get back to getting better results with retraction extension of the neck. So we talked a lot about posture. In my mind, I was thinking that the patient returned about the same because we probably weren't getting to end range without the overpressure, and posture was about the same, meaning we hadn't really cleaned up all that flexion load on the neck throughout the day. So we did talk about keeping posture more in neutral. The patient presented visit 3 about a week later, noting that she still can't sleep on the right side. She did the thoracic extensions 4 to 5 times per day over the chair, and then re-added the first exercise, seated and standing 3 to 4 times per day. The big picture, still reporting she was about the same overall. I asked her, if you were going to grade yourself on posture, A to F, what would you give yourself posture? She said a B. So it depends on the person if I think we really need an A or a B or a B plus to turn the tides with fixing the disorder. For her, I do think it was more important because of the sustained amount of time she did spend in neck flexion. So I take that on board. Postural changes, not as much, not getting there, not an A yet, but possibly a B would be really helpful, and possibly it would be mildly helpful. For her, we might need a lot more attention to that. At rest, today, her hand was okay. She had mild symptoms in the elbow area. I had her demonstrate the home program, thoracic extension, and the retraction extension, and I noted that she wasn't quite getting to end range. So I went back to retraction extension with overpressure. So she'd only looked at it very briefly. We'd never done it officially in the office. So I looked at retraction, extension, overpressure. We did 4 sets of 10. It produced the scap, not remaining worse afterwards. So producing the scap, not the arm, before it produced the arm. And as in the prior situation, the more we did it, the more the pain moved towards the neck. And I really underlined that in my notes, because if pain is centralizing during a movement, then it begs the question, is it going to centralize overall with more repetition? Meaning symptoms are going to move out of the extremity, move towards the neck, and then abolish. I wanted to investigate if the load of prone retraction extension was more beneficial. I briefly looked at retraction in supine before. We've stayed in seated, but I just wanted to make sure I wasn't missing something that was even better, or that was better in prone. So we looked at prone retraction extension for a few seconds. Immediately, her left hand went numb. And so I abandoned it. I don't want to irritate a nerve that's producing paresthesia that quickly. If it took a minute to come on, then maybe I would do, let's do 20 seconds or 30 seconds. Let's do it at a threshold of time that does not irritate that nerve. But if it's coming on immediately, then this is not the right load for this individual. I looked at seated left rotation. So I was going lateral to investigate that. My initial thoughts with a patient who has no symptom production with lateral movements is that I probably have to stay in the sagittal plane. But she also had loss in the lateral movements. It was symmetrical with rotation. So symmetrical loss in rotation left to right. So that's not ringing any bells for me, but there was an asymmetrical loss of lateral flexion or side bend, which is making me think we might need to go to the left. So because nothing has been conclusively fruitful so far, I wanted to investigate a lateral procedure. So I looked at left rotation and it produced mild symptoms, but not worse. And then I just wanted to see what happened with seated flexion, and it was produced no worse, and her strength in her fingers got worse. So I'm not going to be barking up the flexion tree, so to speak. And for left rotation, I'm not going to stay there. It didn't have any effect. And I think I had looked at left side bending and maybe excluded it in my talk right now. I looked at left side bending briefly last time, and there was no effect. So I'm still considering that I need to stay in the sagittal plane. So the home program, again, on visit 3, continue with the postural changes, and make sure you really add that overpressure to get to end range. We know that it's likely to produce the symptoms when you do it, but as long as they're not staying worse, I tell people it's kind of like picking out a splinter. It hurts when you do it, but if you do it enough, it will remedy the problem. And for problems that I think are joint derangements that can be fixed with a specific movement, one thing we are definitely monitoring is what happens when you do the movement. And if there is brief pain that doesn't remain worse afterwards, it's not a red flag, it's a yellow flag. It hurts to do it, but we need to know what happens the more you do it. Because the more you do it, it could centralize and abolish. The more you could do it, it could start to peripheralize and get worse. The more you could do it, it could stay the exact same. That is one of the pieces of the puzzle when I have to decide to continue with the movement, add more force, change the load, such as seated versus supine versus prone, or add sustained as a component, or change the direction, etc. It's a big algorithm, and there's lots of different pieces of data, and that's why repeated movement testing can be challenging for clinicians to learn. It takes a while to understand, but you have to have a theory of mind going into it, which is I'm picturing something in the posterior lateral compartment of the disc if it's on the left, or the joint if we want to be more vague, and how do we need to move this person's joint to effectively resolve this nerve irritation and problem. Now, why have I started to think about that as kind of the disorder for this individual? Well, part of the way I think about these things is, let's say I'd never been to a course to learn mechanical diagnosis and therapy. I know in the old days I would have just been thinking, yes, this is nerve irritation, so we need to kind of fix the spine, and I would fix the spine by doing lots of different things such as nerve gliding and massaging and modalities and stabilization and strengthening and stretching, and probably some joint mobilizations or at least some mobility in non-specific directions. But now I think about it like that's too vague of a diagnosis anyway. I mean, you can say nerve irritation is a diagnosis, but if it doesn't really inform a specific treatment, then it's not a specific idea or diagnosis. It should be clear to most clinicians if a person says, I get numbness and tingling in my fingers, especially in my fingertips, that a nerve is compromised in the lower neck or upper thoracic spine. But of course, we all have very different ideas on how to go about trying to remedy that disorder. But what I want to say is that if you want to think of a diagnosis, I think you can also do it by thinking of what it isn't, right? So for this patient, it's not muscular. She didn't pull a muscle. She didn't get weak all of a sudden. Her muscles didn't get tight all of a sudden. And nothing in her verbal history or physical exam on day one tells me this could be a muscle problem. 2, I don't think it's a tendon problem for similar reasons. 3, I don't think it's a ligament problem for similar reasons. Nothing in her verbal history and physical exam makes me think she sprained a ligament. 4th, do I think this is a fracture, a bone problem? No. And do I think this is another structural problem? Possibly. I think this is a disc problem, but I can get there because I'm ruling out other things. And I think a lot of clinicians, they can say, no, this doesn't sound muscular. No, this doesn't sound tendinous, cartilaginous, ligamentous, bony, but then they don't have an answer of what it could be. And that's where I think kind of joint mechanics and mechanical joint arrangements that are fixed with a specific movement or two fills that void. At least it did for me, because this is not how a muscle acts, right? This is how a nerve acts. But then you would start to think, well, just go in there and, shoot some steroids in there and get the inflammation on the nerve. Well, how do you know that inflammation is on the nerve? If I move a patient in lots of different directions, or several, or 2, depending on the patient, and symptoms just get worse, or symptoms don't change at all, then I may start to consider that the problem is not mechanics of the joint, the problem is inflammation sitting in a joint space or hitting the nerve. But I get to inflammation when I've excluded mechanical joint derangements. The same with structural. I will get to the answer that this is a structural problem. The disc has been compromised, the hydrostatic pressure of the disc has been lost, and now there's nuclear material or annular material sitting on the nerve. I will only get there if I've proven to us that it's not a system that's intact that can respond to movement. So this is a long way kind of saying that I think in order to get to what the positive diagnosis is, you can think about it by just excluding things that it can't be, right? This can't be stenosis because when she flexes, she opens the facet joints or she opens the canals for the nerves and she gets symptoms. So that to me excludes stenosis. Yes, she also gets symptoms when she extends, but she doesn't get symptoms when she rotates to the left or right or side bends to the left or right, which also affect the size of the canals that are impacting the nerves. So I think I used to think more algorithmically about what this could not be, but now it's just kind of like second nature, right? When someone starts to say, my hand's numb and it just started last week and I get worse when I look down, okay, it's not a muscle, right? Move on. But before I'd have to kind of like really go through that checklist in my mind or on paper before I could really hone in on 1 or 2 diagnoses by the end of the verbal history and hopefully narrow it down to a strong 1 by the end of the physical exam and testing. So I decided on this visit 3 to continue with retraction extension to end range with hand over pressure at least 6 times per day. She was always really consistent with doing the homework, so it wasn't a lack of repetition that was stalling any progress that we were going to make. Visit 4 was another week later. She noticed that the symptoms were about 15% decreased. She was consistent with the home program. Now flexion had nil loss still with no provocation of symptoms. Extension now was just a very minimal loss and much less provocation of symptoms before. In the past, when we did extension of the neck in the clinic, it would light up the arm, and then as it got a little bit better, seemingly better, it would light up the scapular area. But now it was a much less. Fingers were still about 4 out of 5, so not normalized yet. Importantly though, flexion or side flexion, lateral flexion of the neck, left and right, were symmetrical. So now we're starting to see that the side bending motion of the neck is more symmetrical. I put that she had a minimal loss of side bending left and right and rotation left and right. bilaterally, no provocation of symptoms. Her home program demonstration was good, and it was much less provocative than it used to be. I again wanted to investigate prone to see if she was now more tolerant, knowing that if someone's not getting sufficient improvement with seated, I will usually go to prone and see a lot of patients who do now see an improvement. Prone retraction extension was a lot less provocative in terms of hand symptoms, but she felt very fatigued and uncomfortable kind of across the upper mid-back. So kind of where the neck hits the mid-back, the CT junction. So that tells me that that's likely, still where something is, because if I were to do that movement or that position, I would feel strained, but I wouldn't feel like, oh, this whole upper area feels really fatigued and not good. But it was a positive thing that it was less productive of hand symptoms, because before it was immediate that the hand went numb. So we're going to continue with the same thing. I wanted her to add prone just for a few seconds, twice a day if she could. And part of the reason obviously is to see if that addition of that was beneficial, but also for me starting to think like, is this something in the lateral component that I've missed? Because if I can make it worse, then I definitely need, or I have evidence that I need to go to the lateral side more and test more in that left compartment. And posture was still part of our conversation. So visit 5, about 3 weeks later, she had been doing it every couple hours. She wasn't quite sure if the one on her stomach was helpful or not. And she said that she was 80% overall better. And she had a sore neck now, which she didn't have before, and very intermittent left hand paresthesia. But the 80% overall better is obviously what really tipped me off that, yes, I think sagittal plane is correct. When we clean up the posture a little bit and get to end range with overpressure, it can be very helpful. Thumbs and fingers were now 5 out of 5. So the fingers was what I had tested the most before in terms of abduction. Now that was normal. Flexion, no loss, but produced a sore neck. So I think her neck was getting very sore from doing all these exercises, but in a good way. Extension, nil loss to minimal loss with a sore neck. And then rotation and lateral flexion still, minimal loss overall, maybe a little bit more loss of range of motion in lateral side bending, but take that with a grain of salt. They were still not producing symptoms when she went to the sides, right and left. I looked at her homework demonstration. I wrote down in my notes that it wasn't quite getting to end range. So we did it did produce neck symptoms when she did it, but not remaining worse afterwards. I revisited looking at prone. It produced some mild left scapular pain that didn't remain worse and had no effect, except it gave a little transient hand paresthesia. So I didn't want to change much, continue with the seated exercise. I reiterated we needed to get to end range. And I don't recall in this particular case, but a lot of patients do have some fear over that. And some people just don't think that their neck should go that far. Sometimes I take videos, I show them the book, I demonstrate myself how far we want people to go, and I have a chair that hits people in the mid-back so that they can really feel how far they're going. Of course, we are extending the thoracic spine if we go that far, but that's the point, because we want to make sure that the very lowest cervical regions are getting to end range. So getting to end range of C6, C7, T1 means that some of the joints below it are also going to be extending, T2, 3, 4, 5, etc. But I do have a lot of patients where I have to kind of continuously encourage them, go further, go further. Think about my voice in the back of your head when you do it saying, go further, 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 right? As Robin McKenzie used to say, or get to end range. And I tell them, end range is where the magic happens. We don't really see results if we just move 80% of the way. Because of the pressurized system and because of the theory of what I think we're doing, it makes sense to me that we really need to get that joint and that disc all the way into extension. Visit 6, which was about 10 days later, she said she had a day where she was for a couple hours in flexion, doing something around the house and didn't have any symptoms nor remember to do the exercises. So she knows that she was better. Mostly, if she was doing the exercise, it could produce a little intermittent hand paresthesia that passed, but overall, she was feeling good. And so we decided that we would probably, just keep going with what we had been doing since she was reporting 100% or close to 100% resolution, and then slowly get down to a maintenance program. But what was nice, I did look at the mechanics, of course. No loss in the sagittal plane without any symptoms. So no loss protrusion, retraction, extension, flexion, symptom-free. And for the lateral movement, side bending and rotation, minimal loss for both of them bilaterally without any production of symptoms. And before the fingers had tested normal, and of course the nerve tension was negative to begin with. So that was the program, was to continue with the neck retraction extension with overpressure, mostly in seated, but in standing if seated wasn't available. And I tell people, for patients like this where the symptoms have not been present for too long, I want you to be normal at this high frequency of exercise for a week before you really start to cut back. And then the maintenance program, as I've detailed before, becomes what the patient needs to keep normal pain-free neck mobility, whether that's once a day, whether that's 3 times a day. Maybe it's only on the days where you know you're in a lot of neck flexion with cleaning or reading, for example. Maybe you add it onto your workouts or only do it reactively once you start to feel symptoms. But if your neck is, if you can self-check, if you can just see if flexing all the way down produces scapular pain, or if extending all the way up produces arm pain, those are your check engine lights. You can check those before the pain becomes there at rest to see if your neck is moving well or not, because then you can do the exercise somewhat proactively. But completely proactively would be doing it to the point where you're never having symptoms when you move or when you're at rest. But maintenance plans look different for different people. It just varies on how important it is to them, if they're okay with just doing it reactively. And I stress to people that maintenance, finding the best maintenance program is a little bit of trial and error on the individual's part. But if you want to just have a recipe, you can do it 2 times a day. Put it into your life, bake it into your life, just like you do brushing your teeth or showering, twice a day. Get this done. And, it only takes about 30 seconds to do 10 retraction extensions with overpressure and sitting or in standing. So this case, I guess kind of the take-home message was, we did not see the improvements initially that either of us had hoped for. It did take some tweaking in terms of, I think, really making sure we get to end range, and B, making sure that posture wasn't interfering. Posture, of course, not just being some ambiguous term, but posture for this patient meaning neck flexion. Lots of sustained neck flexion, I think, is exacerbating to this injury, because retraction extension seems to be helpful. So we got up to 100% at or nearly 100% by visit 6, which is kind of the average I see in terms of number of visits with patients for disorders. But it wasn't clear until visit 4, so that we were really on to the right track. There were signs in our visits that I was seeing, most notably the movement of pain and the less provocation of pain with retraction extension done repeatedly. But I did have to make sure I wasn't missing anything in a lateral movement, wasn't, one of those outliers that gets better with flexion, because that made her worse when we quickly tested flexion. I tried to open up the thoracic spine as an avenue to make retraction extension of the neck less provocative. That did not work. So it wasn't out of the gate improving steadily, but once we really focused in on the exact movement, got that down right with overpressure to end range, got posture improved, that we saw a relatively rapid resolution. The visits were over the course of about 8 weeks. So 6 visits in about 8 weeks. To resolve this, and my diagnosis would therefore be a mechanical joint derangement in the neck with, pain and paresthesia into the left scapular area and upper extremities. This diagnosis, by definition, when I use Robin McKenzie's term, means that it's reversed with movement. If, for example, or specific movement, shall I say, in this case, just one movement, retraction extension with overpressure of the neck. If, for example, a patient who presented with these signs and symptoms did not get better with a specific movement, well, then I would not call it a derangement. I would call it there's an irritated nerve, and it's likely something structural or inflammatory that's hitting it. It would depend on how the person presented specifically, whether or not I was leaning more towards one versus the other. But in order for it to meet the definition of a mechanical joint derangement, it means mechanically it is fixed with a very specific direction. And in contrast, I should be able to make it worse with movement in another direction. So if I had her repeatedly flex every 2 hours, my suspicion, a strong suspicion, is that things would get significantly worse. So this definition, of course, is not really understood in mainstream medicine, but it is what I find in at least 70% of spinal disorders, is that there's a specific movement or two that'll get the mechanics back on track, get irritation off the nerve if there is nerve root irritation, get signs back to normal, range of motion back to normal or as full as it can be, strength returning, and of course I find mechanical joint derangements in extremity joints as well. So consider this as a diagnosis. If you are struggling, find a clinician who knows how to use Robin McKenzie's repeated movement testing as part of their arsenal, because a lot of clinicians, or most clinicians, are not, and they're relying on imaging and quick special tests, or they're just calling it nerve root irritation, or they're just calling it non-specific neck disorders, and then they're providing non-specific kind of treatments, and I don't think the outcomes are as optimal as they could be.